Okay, welcome to the Building Blocks session for preparing the future surgeon. I'm Matt Hartman from Pittsburgh, PA, and I'm joined by Davin Evanson from Drexel University. This lecture can be found on the ACR Building Blocks. What I'm doing is giving you a video preview of what's on there. I'm hoping you'll go back and download the whole thing and go through it on your own time. I'm going to also throw in some Hartman pearls in there, and I think you're going to like it. Here's the QR code to get onto the ACR Building Blocks site. It requires a membership. It's free, but once you get there, it's worth it. Tons of great material for the future surgeon, including lots of anatomy, intro to imaging. The contrast module is especially good. There's a YouTube video for that. The general surgery senior module, which I am previewing for you here. And then the rad path. We have our own rad path channel. The intro to rad path is excellent, and then individual organ systems are covered. This is the rad path channel, especially if you're going into surgery. I think some of these videos will be extremely helpful for you. And if you like Anki flashcards, we have a rad path deck for those, which you can use and download. So I'm a body imager. I love rad path, and I want to prepare the future surgeons and our future interns. So that's my goal here, guys, get you ready for either the clerkship or internship. So we will be learning how to talk the talk. We'll go over some key concepts, and I'll throw in some Hartman pearls, and then Davin will show you an interactive case. One of the best things about this whole module is there are a ton of interactive cases at the end. So I implore you to join the Building Blocks site, download the entire module. Again, I'm just sort of showing you a preview. And the great thing with YouTube, you can pause me at any time, fast forward, put me on double speed, whatever. But I implore you to download the actual module. So this is intended for fourth-year med students, future interns. I think it's great for someone doing the surgical clerkship as well. It builds on previous material that has already been described in the building blocks. If you need to download any of that stuff, review it, please do that. So talking the talk. So bowel distension. And for a lot of these slides, I'm just going to sort of go through it, not talk too much unless I have something to add. But you can pause, fast forward, whatever you want to do. So normal caliber here, as opposed to bowel dilation. We're going to learn the rule of threes. Small bowel should be less than 3 centimeters. If it is more than that, it's dilated. And we learned from the Hartman rad path videos that dilation is one of our 6 patterns. Ileus. I think of this as a clinical scenario as well. You often have a history of recent surgery, patients on big-time narcotics. You don't hear any bowel sounds. What are we going to see on the imaging? Well, it depends if it's a local ileus or a complete ileus. Local ileus, especially pancreatitis, it might just be a lot of air in the upper abdomen. And adynamic generalized ileus, we've got small and large bowel all the way through. A lot of times the stomach is dilated too. You often have a history of a recent surgery. And there's some free air under the diaphragm. We'll learn about that with a lot of burps and farts, but always looking for free air under the diaphragm. Okay, obstruction. We have dilated bowel loops to a certain point. We will have a transition point. There's no colonic gas anywhere, just small bowel loops. And we'll talk about how to tell small from large bowel. This is small bowel in the center. We have stair stepping here. That is a good sign for small bowel obstruction. No distal gas. So we are looking for that transition point, often easier to tell on CT. Dilated, again, that's one of our Hartman 6 pattern words, to a certain point where it is narrowed. We're always looking for a closed loop obstruction. That's a surgical emergency where you will have sort of a hairpin and 2 points of narrowing. So large bowel obstruction. One of the things, how do you tell small from large bowel? So it's easier said than done sometimes, but large bowel is usually more on the periphery. Large bowel rule of three, small bowel is 3 centimeters, large bowel is 6, cecum's 9. So if it's larger caliber, that is most likely going to be colon. Again, there's stool in there. That looks like large bowel to me. No rectal gas. I'm thinking large bowel obstruction. We'll come up with a differential for this. Pneumatosis, air in the wall of the bowel. This looks like a kid worried about neck. In this instance, anytime you hear there is pneumatosis, be worried as the future surgeon. We're then going to look for portal venous gas going up to the liver, and we'll see that later. But you hear pneumatosis, be thinking ischemia. Extrav, this is a pattern of Audi. They had a fluoro study contrast through the esophagus, and the contrast goes outside the esophagus. Big time leak. So again, watch the RadPath video, the 6 patterns. You have a tube, only 1 of 6 bad things can happen here. Here we have a outpouring, outpouching of contrast into the peritoneum. That's why we try to do it with water-soluble contrast first. It's not a good thing to have barium in the peritoneum. It will cause a granulomatous reaction. Here we see on the CT all that high-density stuff. Filling defect. So this is what I call an INI with the Hartman 6 patterns. You have your tube. Here's the collecting system. We're in the pylographic phase. There is a filling defect in the renal pelvis. That's very suspicious for a TCC. Here we have a pulmonary artery PE study, and there's a filling defect in the pulmonary arteries. That's going to be a blood clot. So that's what we mean by INI or filling defect. Exophytic. So that's helpful describing. Again, anytime you have a mass, try to say, is it solid or cystic? And then the next thing is infiltrative or exophytic. So here's the exophytic. It looks like a water attenuating cyst to me. This is a more mixed solid and cystic, probably necrotic mass. That looks like bad news. And for those going to thoracic surgery, lung nodules, less than 3 centimeters. And then lung masses, more than 3 centimeters. Chest x-ray is one of the hardest things to read. It takes lots of practice. And that's why we have the Truth Machine, the CT, to help us. Okay, fat stranding. What do we mean by that? Well, there's lots of fat in the sub-Q, the retroperitoneum, the peritoneum. And here you can see some haziness around this tubular structure. This is the appendix. This is fat stranding. The appendix is a little bit dilated. Again, that's one of our pattern words. It's probably thickened as well, inflamed. This is going to be appendicitis, so dirty fat. We'll see that in lots of itises, cholecystitis, diverticulitis. That's how it will show up on CT with fat stranding. So I hope everyone understands Hounsfield units. This is a measure of CT density going from -1,000 for air to +1,000 for metal or bone. Water is 0, fat is -100, blood will be about 30. So this has been shown on earlier videos, but a nice review. There's our fat, -100. And then we can use this to window. Basically, you're just changing where you want your grayscale. If you want the negative numbers for lungs, that's lung windows. If you want soft tissue windows or bone windows, that's all we're doing is manipulating the grayscale. MR, again, this is something we've covered before. T1 versus T2, T2H2O, the CSF is bright. And we go over this in more detail on the neuro videos, but flare diffusion is great for stroke. Enhancement. So we can see this with CT, MRI, even ultrasound if we use contrast, which is microbubbles. But we're looking, the value of adding contrast is lesions will appear, vascular structures will appear, but this is going to be a cirrhotic liver, a arterially enhancing lesion. This is suspicious for HCC. Okay. So let's go over some key concepts, how to read an abdominal radiograph. I'll repeat this with the Hartman pearls, but I like this version. It's important to know how the film was taken, upright or supine, and our mnemonic is going to be stones, bones, mass, and gas. We're usually doing this because patient has pain and we're looking for the source of the pain. And we always start with lines and tubes. Whatever you do in chest x-ray, KUB, CT, always look at lines and tubes. That sort of goes under stones. Anything radiopaque, we have to explain, but always start with the lines and tubes first. And we're see some gallstones there, right upper quadrant. Bones, we're looking for fractures, we're looking for mets. Masses, here we can see the liver shadow coming all the way down, hepatosplenomegaly, spleen coming all the way down. In the GYN module, we have a big pelvic mass displacing the bowel out of the way. This is one of the hardest things to do, but you're looking for the bowel being pushed out of the way. Then we save the most important for last. It's bowel gas, normal or abnormal. We have to know how the film was taken. A lot of burps and farts. Was it upright? Sometimes it will say you'll have air fluid levels, or supine, because free air obstruction will look different whether it is the film is taken upright, supine, or lateral. So here is some information. You can stop and read about what makes up an acute abdomen series. And here are some images of small bowel obstruction, small versus large bowel obstruction. Again, this one's helpful. It's upright, so we get the air fluid levels, the stair stepping at different levels. This is a small bowel. It's in the middle. We got the valvulae conavente going all the way across, and there is no distal gas. Here, large bowel obstruction, that looks like the transverse colon, more peripheral, all the way sort of to the sigmoid colon. I'm worried about a big mass in the rectus sigmoid colon. And you can look at this slide on your own, how to differentiate small bowel from large bowel. The small bowel has the lines going all the way across the valvulae conavente. The large bowel has the haustra. One of the most important things is ruling out after surgery. We get asked to make sure there's no foreign bodies. Again, stones, bones, mass, and gas. We're looking for anything radiopaque. I'll give you guys a couple seconds to look for the radiopaque things. And the first thing we see is this ribbon. This is sponge. They sort of tag it with extra radiopaque material so that we can see it. So hopefully everyone saw that. Is there anything else? Well, I see a ureteral stent and a drain. So we're responsible for everything on the film. So enhancement, we talked a little bit about this. It's useful to have a non-enhanced study first. This is without contrast. You give contrast, the aortas lighten up, the kidneys are lighten up. That's usually done at 30 seconds. We wait 70 seconds, now the portal vein is lighten up. Our aorta is less bright. And we wait 5 minutes and the kidneys are excreting contrast. This is called the excretory phase. And a lot of radiology is pattern recognition. So we're trying to see how these lesions are doing, if they're enhancing, if they're washing out, early, late. That's what a lot of radiology, especially abdominal imaging, is about, learning the patterns of enhancement for these lesions. I'm trying to decide if a lesion is benign, like a hemangioma, indeterminate, I can't tell, or definitely suspicious, like a HCC. Okay, I'm going to go a little bit fast through this. You guys can pause it. You can go back on your own time, but the approach to reading an abdominal CT, to look at the vessels, and the module does a great job showing the different vessels, celiac axis, SMA, renal arteries, iliacs, the portal vein, and for the liver, again, the different phases. Here's, this looks very similar to the other case, cirrhotic liver, arterial phase. We have arterial enhancing lesion. We wait 60 seconds, and the lesion has washed out. This is a different patient. This is a lesion we wait on the delayed phase a couple minutes after, and only now is the lesion enhancing. This tells me it's a fibrotic lesion. There's some capsular retraction, maybe some biliary dilatation. This is great for a cholangiocarcinoma. Again, we go over this in the rad path of the liver in more detail, so I encourage everyone to take a look at that. So gallbladder, using ultrasound, CT, MRI, nuclear medicine, we're looking for innies. There's a gallstone. We're looking for dilation, distension, that fat stranding for cholecystitis. Adrenal glands, we have a rad path about this. Benign, adenoma, Mets, lymphoma, PHEOs. We run the gamut. Same thing with the pancreas. Great job on the rad path for that. Inflammation, pancreatitis. Is it just simple or is it necrotizing? And that's going to be probably the bane of your existence as a future surgical intern. Don't mess with the pancreas if you can avoid it. And then in the more chronic phase, pseudocyst or walled-off necrosis. Kidneys, for any of the future urologists, we do a great job on the rad path of the kidney videos. You do non-enhanced for stones, give contrast, looking for lesions, and then the delayed phase, which we talked about, looking for filling defects such as TCCs. And this is a nice example of a reformat showing an RCC, solid exophytic mass. Bowel, the rule of threes, shown there nicely. There's our transition point, small bowel obstruction. Then lymph nodes, of course, Mets lymphoma. Maybe they're reactive. Looking all over the body for these. Don't forget the musculoskeletal system. So psoas hematomas, retroperitoneal hematoma. You will see these in our sick patients who are anticoagulated. This is what we're looking for. And same thing in the rectus muscle. The pelvis, we have the bladder, the reproductive structures. Do a great job in the GYN rad path if you want to take a look at those. Fluoroscopy, one of my favorite things, basically doing live time videos while the patient swallows or injects contrast from any orifice, whether above or below. For pediatric surgery, newborn with bilious vomiting, rule out malrotation. This is what we're looking for. The duodenum does not cross the midline, instead spirals. This is a surgical emergency. We need to take the baby to the OR to unvolvulize the gut. Great for looking for fistulas, ulcers, leaks, and we'll use water soluble for in those instances. We have for those going into breast or on a breast surgery rotation, we have a full rad path on breast, but be familiar with the BI-RADs. Any woman that gets a mammogram will get a score from 0 to 6. Nuclear medicine makes a lot of physiologic sense, and it makes a lot more sense if you actually get to spend a day in nuclear medicine, which I have all my students do. But basically, you're injecting a tracer into the patient, usually tagged with technetium. In this instance, using HIDA scan. It goes so HIDA agent, some diacetic acid gets taken up by the liver, will be secreted into the bile in a normal patient. The bile goes into the gallbladder, and then gets excreted into the common bile duct. That's good. Now, for a patient with GI bleeding, you'll see a lot of this as future surgical interns. Several options. You can do a CT angio study, which may or may not show the bleed, and can do a nuclear medicine test where you tag the patient's own red blood cells, tag it with technetium, re-inject it into the patient, and you're looking for where the blood is pooling here in the transverse colon, it looks like. And that tells the the surgeon where to look for. A lot of times, there'll be radiology doing embolization of that area once you confirm the bleed. often use nuclear medicine for staging cancers, something called the sentinel node, where you know where the cancer is, you inject that site, and then can see where it spreads to with the lymph nodes. That tells the surgeon which lymph nodes to remove. And then finally, PET-CT. This is something that was really starting to come out when I was a resident, 15, 20 years ago. You use radioactive sugar going for any area of metabolism, including cancers, and really helps you stage the cancers. You'll see the primary, but then you'll also see the metastases. So this was sort of a whirlwind tour of principles, vocab for surgery. Again, download the whole module. I want to throw out some of my own pearls, which I share with my own students. Some of this is repetition, which is good. Some of it is a little bit, was not covered in the module here. So how to read a KUB. Stones, bones, mass, and gas. Again, always do lines and tubes first. And we have to remember the law of burps and farts. Air will rise. So it's very important to know how the study was done. Was it upright or supine? If it was done upright, free air will be under the diaphragm. And you'll have air fluid levels for small bowel obstruction on the upright films. The rule of threes. 3 centimeters for small bowel, 6 centimeters for large bowel, 9 centimeters for cecum. If the small bowel is more than 3 centimeters, it's dilated. We are worried about an obstruction, so we're going to look for that transition point going from dilated to narrowing. And then this is one of the most helpful things for thickness, whether you're doing the gallbladder, the bowel wall, the bladder wall, whatever. Most lumens are 3 millimeters or less for thickness. If it is more thick than 3 millimeters, that's usually abnormal. It's usually inflammation. So we saw the nice case of the appendicitis, the cholecystitis, you have cystitis, a thickened bladder. That is the pattern we are looking for. More than 3 millimeters is abnormal. And why is it thickened? Well, we go over this in the chest, but think of something infiltrating the wall. Blood, water, cells, or pus. It could be hemorrhage. It could be edema, low protein state. It could be cells from either inflammation or lymphoma, or it could be an infectious enteritis. I love this mnemonic for small bowel obstruction. This works extremely well, especially for peds. AIM, adhesions, appendicitis, inguinal hernia, intussusception, malrotation, Meckel's. For large bowel obstruction, add cancer and diverticulitis. Air in the liver gets there one of two ways. It's either in the biliary system or it's in the portal venous gas. And this is a great mnemonic that I stole from EM Notes. Actually, I had heard this before, but this is the best description, visual description I've seen. Portal venous gas will be peripheral. Again, we worry about pneumatosis, ischemia, going from that air in the bowel wall, going up the mesenteric vessels. It's going to end up in the liver. This is a horrible prognosis. These are very sick patients. If you get the phone call from the radiologist that there's portal venous gas, be very worried about ischemia. As opposed to more central air in the liver, this is in the bile ducts, CBD, central bowel gas. Usually you'll have a history of ERCP, sphincterotomy, not as worrisome as the portal venous gas. So I encourage everyone to watch the RadPath video, the Hartman 6 patterns of any tube. 1 of 6 things can go wrong: innie, outie, narrowing, dilation, thickening, and displacement. Every differential, and that's lymphoma.
Awesome. Thank you so much, Dr. Hartman. That was absolutely fantastic. A lot of really good information in there that can be found in that senior module for surgery. I did surgery as my first rotation, and I wish I had seen this stuff and been able to use this on my surgery rotation, because they like to ask us questions about CT and where the transition points were and the fat stranding and if there was a obstruction or diverticuli. And so I think this is super important for clerkships, for that 4th year doing rotations in surgery, and for interns as well. I'm Davin Evanson. This is the start of just 2 of the cases that are shown in the module. And there's multiple more that are super good to go through, and some really high yield cases that a surgical intern and resident will definitely see. First one, we've got an 80-year-old male, hasn't seen a doctor in 40 years, presents with nausea, vomiting, and distension. We get a acute abdominal series and we see this upright abdominal film. Again, we're looking at if there's lines and tubes, don't really see any stones. No, bones look okay. Mass, can't really see anything, but gas is not looking good here. Again, laws of burps and farts. A large bowel obstruction is diagnosed, and the patient is referred for barium enema to better characterize the obstructions. Why does this person have this obstruction and dilation of his large bowel? Again, we don't have measurements here, but greater than 6 centimeters. I could believe it might be that. So here's a barium enema with a previous patient. Where is the reason that this person has that large bowel obstruction? There's a apple core lesion, and that's pathognomonic for colon cancer. Can you see that anywhere? Right there. See how there's that narrowing of the lumen, and it produces kind of that core of the apple? Of course, there it is. Patient has also extensive diverticulosis, an example of that right there. Most common causes of large bowel obstruction are colon cancer, a hernia volvulus, diverticulitis, and intussusception. So those are definitely things to be concerned about. And with that apple core lesion here, most likely cancer. Great. Another one, a 75-year-old female presents with abdominal pain, distension, nausea, and vomiting. Here we're thinking probably a small bowel obstruction, possibly complete. What tests do you think we should order to establish this diagnosis? CT abdomen and pelvis. Should IV contrast be used? Yes, as long as there's not a contraindication, some sort of kidney injury or something like that, or allergy. Should enteric contrast be used? No, enteric contrast could prevent the detection of the diminished bowel wall enhancement due to ischemia, and oral contrast is not well tolerated in patients with bowel obstruction due to the nausea and vomiting this patient has. Is there an obstruction here of their CT that was done with IV contrast? Small bowels become obstructed due to adhesions from a prior abdominal surgery. So hopefully you get that from their history right there. And what can we see here? Transition point. Bowel is dilated proximal to the obstruction and collapsed distal to the obstruction. So again, that 3 centimeter of the small bowel. And adhesions are the most common cause of small bowel obstruction. What if they also had this as a film from the acute abdominal series? What do we see here? There's free air underneath the diaphragm. And this is most likely a perforation somewhere along that GI tract from that obstruction. And a long-standing obstruction can lead to ischemia, which then can cause this rupture. And this is a medical emergency. There's also, if a patient can't be laying flat, you can get a left lateral decubitus film. That can also be helpful, especially with the density of the liver. Makes the error more obvious. And that's it for the cases. Again, go check out the senior module. Get a membership to ACR if you need. It's free for medical students. This is really important stuff to understand as a surgical medical student on your clerkship and as a surgical intern. Thanks, and stay tuned for other videos.